this video, we're going to talk about the latest technologies that help you monitor prostate cancer, but specifically also profile prostate cancer. So what type of prostate cancer is it, and what is its chances that it's going to metastasize? This is important information because it can help you go on active surveillance and maybe postpone treatment, but it also can help you identify what treatments would be best for you. It'll help you know what type of doctors you need on your medical team and understand the timeline of maybe when to treat or not. It's an important thing to kind of hone in on and understand, because the more you understand about your particular type of prostate cancer, the more you can get personalized care. So today I'm talking to Dr. Mark Scholes, who's a 30-year medical oncologist who specializes specifically in prostate cancer, and we're going to have our questions answered. So, Dr. Scholes, we're sitting here at the end of 2024, and we have a lot changing in the prostate cancer world. We've seen new treatments and new indications. There's just a lot happening, to the point that even patients really have to stay up to date on their own particular case and what is changing and available to them, because there is so much happening, and a lot of times their doctors are not as up to date because they have to treat multiple diseases, and there's just so much happening. It's hard to keep up even for physicians. So, can you talk about some of the new updates and the new things that we're looking forward to in the future? Because one of the great things about prostate cancer, if there is a great thing about having prostate cancer, is that you can be grandfathered into other treatments if you have a treatment that's working for you, and then it works for maybe 10 years, and then you see new technology over time. So it's an exciting prospect when it comes to these situations.
Prostate cancer being a slow-growing disease, sometimes we have the luxury of watching it over a period of time. One of the payoffs of that luxury is that new stuff can get invented in the interim. So here in 2024, someone's going to start on active surveillance. Maybe there's a little uncertainty as to how safe it is. Maybe they have some 3+4. It's not a pure 3+3, but they want to kind of bet on the come. And that would be a foolish thing to do with practically any other type of cancer besides prostate cancer. But with prostate cancer, it is actually possible for people to live many years, even with the more serious variants. And then a new discovery comes along, and it's like they catch another wave and they can have their life extended further years. Sticking to the example of men who are contemplating active surveillance, one of the things with these new PSMA PET scans, which we've talked about a lot on this channel, is the idea that when someone walks in the door newly diagnosed with prostate cancer, we know that that cancer's already been in their body for years. Cancer starts as a single misbegotten cell that then multiplies, and over time it gets big enough to be detected. If you look at a tumor that's a half-inch across, that's about 10 to the 9th or a billion cancer cells. So a billion cancer cells doesn't spring up overnight. It takes a while for a single cell to grow to be a billion cancer cells, especially in a slow-growing tumor. And we're always in the assessment of active surveillance trying to predict what the chance is for metastasis. Metastasis are the one bad thing that we want to avoid at all costs. It's a preamble to disability and death even. Since not all prostate cancers metastasize, how do we sort out which ones are likely to metastasize? And we've used Gleason score, we've used tumor size in the past. If we think of PSMA PET scans as telling us here in the present tense, has something spread? We think, well, yes, that's true. There's nothing spread today. The scan is clear. There's no metastasis. But does that guarantee us that in the future there's going to be a lower risk of metastasis? And we don't think in those terms, but perhaps we should start thinking in those terms, because that tumor that we're newly diagnosing has already been in that patient's body for years. And the absence of metastasis on a PSMA PET scan does suggest that that person has a lower risk of future metastasis because one hasn't already occurred. Men can come through the door and have PSMA PET scans that do show metastasis, and those are certainly the more dangerous variants, as they're already showing metastasis, the one thing that we really care about in the cancer world. Repurposing PSMA PET scans, not just to decide if there are metastases present or not, but also use that information to assess the type of cancer that individual has. There are literally thousands of genetic variations of prostate cancer, all with greater or lesser risk for metastatic spread. And it's more valuable to know how that person's cancer is behaving than it is how all the other, their Gleason 8 tumor and all the other Gleason 8 tumors that we're extrapolating from, because we have a history of how Gleason 8 behaves. We can profile these people with Gleason 8, but they don't all spread. Some Gleason 8s are more likely to spread than others. And PSMA PET scans, I think, are one early step, reusing or utilizing these PSMA PET scans as an insight into the type of cancer that person has, not just whether it's spread or not, but whether it's likely to spread in the future.
Before I get to my next question, I just wanted to remind you to click that subscribe button because it's a great way to support our channel. Also, if you would like to support us financially, you can do so at pcri.org/donate. And we do have an in-person conference coming up in September, and you can learn more at pcri.org/conference. Now back to my conversation with Dr. Scholes. Why is it that you have some like Gleasonates that go really fast and some Gleasonates that go, in a longer duration of time before they metastasize? What is it about the cancer and the cells that is causing this?
We revere Gleason score because historically that's been the best way to project or profile someone and make an estimate of what the future behavior is going to be. Although it's better than everything else we've had up to the time of PET scans, it's not that great. There's a lot of Gleasonate tumors that don't spread. And we have to treat those people aggressively because we don't have a way to drill down deeper and know with certitude that it will spread. I have a patient in the practice I've been watching for 12 years. He was a stubborn fellow. I kept telling him to get treated for his Gleason-8. And he had a PET scan 6 months ago, and he still has not had any spread, even though the tumor in his prostate has gotten bigger over the years. I think an overestimate of the accuracy of Gleason score, even we rely on it heavily because it's the best we've had, and we revere it for that purpose. But it is not actually that precise. And if you think of other analogies, tall men are better basketball players than short men. But then there have been some incredibly short, basketball players that are playing in the NBA. As a general rule, taller is better. As a general rule, higher Gleason score is worse. But it's not a 1-to-1 ratio.
One of the terms that I have found to be quite helpful is your metastatic risk score. If you kind of think about it, if we were to create a scoring system where, which is basically the Gleason score, of saying how likely is this to metastasize, because that's when prostate cancer becomes an actual problem. I think a lot of people who come into it go, oh, it's cancer, we got to get it out. But in 50% of cases, it's Gleason 6, which, is not going to metastasize. We've seen multiple clinical trials and so much proven data proving this, and that if you do have prostate cancer later, it's a new tumor, which I think a lot of people don't really understand. So we're talking about a different tumor that has a different risk of metastasizing separate from the Gleason 6. So what other things besides PSMA do we have in order to help predict that score, that metastatic risk that we'd be looking at?
Well, one thing I think isn't being addressed in this active surveillance world is the value of time gained under surveillance. When people first get started doing active surveillance, there's a lot of trepidation. But we have men, have been watching their tumors for more than 10 years, and there's a certain boredom and repetition of, the PSA is the same, the MRI is unchanged, another year gone by. Do we really need to be doing this? And that, of course, is very reassuring and comforting for people, and they do emotionally get calmer and calmer as more time goes on with the assumption that, well, if it hasn't spread yet, maybe it's less and less likely to spread in the future because of all the time that's gone by. There's some logic in making that assumption. The concern about spread is that certain types of cancers have the biologic capacity to spread, other types don't. We know that our ability to parse out those that can and can't is not always perfect. I mean, 3+3 is very clear, but we're watching more and more 3+4s now. Which of the if 3% of 3+4s, favorable 3+4s are going to spread, are you in the 3%? I mean, that's a big deal. The test case of having someone that's been watched for 5 years and nothing has shown up, to me, argues strongly, much more strongly maybe than even what the Gleason score was, that person has a variant that is very unlikely to spread. We've given it an opportunity. We've given it time. We've observed it carefully. Spread has not occurred. It's not like, when you invest in the stock market, they say past behavior will not predict future outcomes. But in the biologic world, we trust past biologic behavior to predict future outcomes. So I think there's an advantage to active surveillance. A couple of advantages. We talked about the fact that you might grandfather into better technology by postponing treatment. But you also, as time goes on, you learn about the behavior of the tumor in that individual, not prostate cancer in general, Gleason 6 in general or Gleason 8 in general, but how that particular tumor in that particular individual is behaving. It speaks loudly for whether, if things have gone well for a period of time, that things are going to well for a more extended period of time.
I've noticed some patients stop monitoring after a certain point in active surveillance, which to me is quite dangerous, because if you do have the potential of getting a different cancer that pops up and you're not monitoring, you're not getting your PSA tested, you're not getting the annual MRIs, it is quite dangerous because you're not really monitoring how your current prostate cancer is growing and what the potential risk for a new cancer is coming. So, is there anything else that men need to do for active surveillance besides PSA, besides annual MRIs, to make sure that they're monitoring properly, and make sure they're really taking care of the situation? Because I've seen guys where they're on active surveillance for 10 years, they stop, year 12 is when something pops up.
We at the PCRI have become very acclimatized to using MRI rather than doing random biopsies every couple of years, which is, I think, still considered the national and the world standard for active surveillance. Transitioning from random biopsy surveillance to MRI surveillance, I think, is getting to be very, very strong. This profiling process that we're talking about, someone who has been watched for a while and the shoe hasn't dropped, that their outcome is going to be more favorable than someone who's just starting off, we're just beginning to watch. The beauty of MRI screening or MRI surveillance is that they can put calipers on a visible spot. Let's say it's 8 millimeters in maximum diameter, and then look year to year sequentially for any growth or change. This is a very precise, you're really drilling down into the essence of what we're watching. And there's a difference between spots that enlarge or evolve, in which case you do a targeted biopsy and see if the grade has changed, and the spots that just sit there year after year and don't grow, which is the norm. Usually these things remain unchanging over many years, and we're very comforted by that. But the utilization of MRI as a surveillance method is still not considered mainstream. Men are getting random biopsies on a periodic basis. A far less accurate and a far more uncomfortable way, and even potentially dangerous way to monitor are these random biopsies. Profiling people by the behavior of the tumor in them, not profiling on the basis of the way similar tumors acted in other individuals, but profiling the tumor on the way it behaves in them, I think is going to become ever more popular as our tools for monitoring become so much more sensitive to the detection of very small changes.
No, I think that's a very important context, because we hear the words personalized medicine. And, you see all these new genetic testing, genomic testing. We see these assays where you can kind of predict the effects of side effects of possibly like radiation and things like that. The issue is, it's just like the, internet. If you Google prostate cancer, you're going to get a lot of information. Well, there's also a lot of personalized information where doctors will say, oh, this is for you or this is for your type. So the actual process of knowing your specific type of prostate cancer, really diving deep into how it's acting, how is it acting in the past? What's the potential risk for the future? And then figuring out exactly what tests or assays or treatments will work specifically for you is a lot of work. So, speaking of genetic testing, what type of genetic testing can these types of patients get to help give them a clearer picture of exactly what type of prostate cancer they have?
Many in the industry think that genetic testing, is like the new ultimate, and that it even surpasses Gleason score as a way for profiling people and helping them predict this development of metastasis sometime in the future. The industry of monitoring is being done by a lot of people who are doing it part-time. Surgeons would rather operate and they'll do a little active surveillance. Radiation therapists would rather radiate, but they'll do a little active surveillance. And so the genetic testing industry, there's 3 products out there, Decipher, Prolaris, and Oncotype. They're all reputable, and they throw you on a curve of in their database, they've got a lot of people who've gone through or been evaluated with genetic testing, and some have a greater propensity for metastasis than others. And that's useful information. And this is the same thing that Gleason score does, and they've shown that these genetic tests add something beyond the predictive power of Gleason score. So they do add something. Why aren't I thrilled and recommending everyone get genetic testing? Well, I'm concerned that these companies go too far because they use their databases, which are typically outdated, to actually provide percentage likelihoods of metastasis and death. And I compare that to the outcomes that we see in our office, and these are really bleak and grim numbers. They are just outlandishly negative, way, way, way worse than what I see in my day-to-day practice. And I think I understand why. This was all done in an era when they didn't have PET scans, they didn't have MRIs, they didn't utilize MRIs, and they weren't watched that closely, honestly. And so the outcomes were people who were watched that should never have been watched, and then the people who were watched were perhaps not watched as closely as they should have been watched. And they could predict, and using that type of methodology, you're going to have more negative outcomes. So if people can be disciplined about these genetic tests and just look at where they are in the spectrum, are they at a higher risk or a lower risk, and then walk away from all these, like there's an 8% chance of death at 15 years type of predictions, which I think are amazingly pessimistic. In fact, I am always concerned ordering these tests because informed patients should be looking at their reports, and they're looking at these and they're like, gosh, I've got a 8% chance of dying in 15 years, which in a newly diagnosed patient with early stage disease, that's ludicrous. The modern medicine has pretty much eliminated mortality for men who have early diagnosis where active surveillance is on the table for discussion. Mortality rates at 10 years are going to be 0 for everybody. Could someone end up needing treatment? Of course, that's a different issue. But postponed treatment is better than immediate treatment because you're going to be treated with the advances that come over time. This idea that if I won't go on active surveillance for 2 or 3 years and then have to have treatment, that's a bad thing. That's a good thing that people can postpone treatment. So the genetic tests are an enhancement of the way we use Gleason score to profile people. They have utility, but I just warn people to be very careful in reading the reports and reading anything into these predictions about this person has this % chance of this bad thing or this, because I don't think those are realistic predictions in this modern era.
Well, I mean, it makes sense because one of the conversations that I've heard you and Dr. Moyat have at the conferences or Dr. Kwan, it's you never know how a treatment is going to affect that particular type of prostate cancer. So even the data that you're getting from these genetic tests are before treatment. So you're talking about a context where they can't tell you the exact type of genetic makeup for this exact treatment to work on your particular type of prostate cancer. Even the word cancer is such an emotional impact that it's really hard to contextualize all of the information, especially being a layman who's coming into the situation. And then you're having to say, well, they told me I have Gleason 9 and that's a more advanced disease and I'm reading the statistics. But if you go online and you read the American Cancer Society, even in advanced cases caught early, we have a 99% rate at 5 years, which is huge, especially in comparison to other types of cancer. So even though I agree, like in the sense that genetic testing is exciting and I'm glad we have it, it is really hard to get those helpline calls where patients are really scared. So I really appreciate how you contextualize that. Now, as far as we've talked about PSA, we've talked about PSMA, we've talked about MRI, we've talked about genetic testing, what other things are there besides those things to help really characterize these disease types?
Well, I think those are the big things, and we've sort of narrowed our discussion to the active surveillance space. Prostate cancer is such a huge thing, and we'll probably just stick to this little subtype where people are considering active surveillance. The other thing that we've gained is experience and knowledge. As doctors have only been watching prostate cancer, you could say at most for 20 years. Probably many doctors got into the active surveillance mindset maybe 10 years ago. Well, 10 years in a prostate cancer patient is actually a somewhat short period of time, and you could have a Gleason 8 that wouldn't spread for 10 years. That can happen. The sophistication that is being developed with artificial intelligence and these things where you're putting all this information together, because how much do you weigh the Gleason score? How much do you weigh the genetic testing? How much do you weigh tumor size? How much do you weigh the fact this patient had a PET scan, there was no metastasis? How much do you weigh the fact that they've already been under surveillance for 4 or 5 years, nothing's happened? We're learning, that's a learning process. And certainly there's experience involved, but the ability to really maximize and suck all the useful information out of all these different resources and put them together in a balanced way, only then make a decision about what to do. I think that's a growing field as well. And hopefully the active surveillance resources that are starting to come out will incorporate all these factors. My concern is the PSMA PET scans, the information of sequential MRIs annually, whether there's any growth or not. These newer ways of thinking, the time that you've been under surveillance and that nothing's happened, are not being incorporated into many of the new algorithms, even with artificial intelligence. So they're looking carefully at Gleason score, PSA levels, percentage of core biopsies positive, which is another way to look at tumor size. But they're not incorporating some of these newer issues like PET scans, which I think is ridiculous because these newer methods are actually more powerful than the older methods.
As Dr. Scholl said, a lot of the data that we're seeing is pre-PSMA data. And it's a lot of information to take in. You know, the word cancer is scary. Well, the word death on a genetic test report at 8% at any percent is also very scary. So what I would encourage you to do is to find somebody on your team, whether it's your doctor or a second or third opinion. Maybe it is a nurse in the office. Maybe it's a caregiver. Maybe it's a nurse navigator, or maybe it's helpline at pcri.org/helpline. They can help you contextualize all this information because you want to take care of your mental health and you want to take care of your emotional health through this process. You're a person going through all of this. And a lot of times when we talk about data, when we talk about statistics, all of this is pulled from thousands, of patients, hundreds of thousands of patients as you look at clinical trials and genetic tests and all the data that we see with MRIs and all these different things. You're a specific person who's dealing with a prostate cancer diagnosis, and now a ton of information is being thrown at you, and you are being encouraged by a world-renowned expert to contextualize it. Well, you need help to contextualize it. So I would really encourage you to reach out and get the help that you need, whether it's, watching more of these YouTube videos, joining a forum like Health Unlocked, asking questions in those forums, maybe going to a support group or calling Helpline, or even just reaching out to the people in your medical offices. All of these are resources that you can use in order to help you learn about your specific type of prostate cancer. Now, I know we're talking about the active surveillance context, but one story I want to highlight that I feel like is really important for this video for this reason. So a good friend of mine had Gleason 9 prostate cancer. He was 52 when he was diagnosed. And he was very upset. He was given 5 years to live. And he was, very frustrated because he had 2 daughters who he wanted to see graduate high school. And, he was just going back and forth, but he learned about his specific type of prostate cancer, and he didn't take that timeline that the doctor gave him as this is what's absolutely going to happen. So he went and he got on a hormone therapy. He was on a first-generation hormone therapy. And ended up working for him for over 25 years. And not only did he see those kids graduate high school, he got to meet his grandchildren and spend a lot of time with them. And he lived another 25 years after a Gleason 9 metastatic, case where he was given 5 years to live. The point of that story is that that specific treatment worked really well for his particular type of prostate cancer. And now when we have so much happening when it comes to these new treatments here in 2024, you don't just have first generation, you have second generation, but you also have genetic testing. We have PARP inhibitors for other immune therapies and other types of cancer that you could possibly get in prostate. There's a lot of hope. There's a lot of tools in the toolbox as we hear a lot of our oncologists talk. And so there's different combinations. Now we see spot radiation. And now, as Dr. Scholes was talking about, you have PSMA imaging where you can see what the cancer is doing and have a clearer picture of not only its risk of metastasizing, but if it does metastasize, you have a better chance of seeing where it is. And we have treatments that can affect those particular spots. And if it's metastatic, you have more systemic treatments. So the whole point of this is if you're an active surveillance patient and you are monitoring, which is fantastic, and it is intense when you think about, well, it's, hasn't done anything in 10 years, why should I continue? Please continue, because I do talk to guys, as I mentioned, where they stop and something pops up. It's just a really great way to protect yourself from anything happening in the future that you just don't know about. But again, you want to know about your specific type of prostate cancer as much as possible. So as you're layering on these new technologies, whether it's MRI, whether it's genetic testing, whether it's targeted biopsy, whether it's getting a second opinion on your pathology report to make sure it's that specific type of prostate cancer, whether it's getting a second opinion on your MRI and making sure that you really know the size of your prostate, how your PSA should be acting. All of this is a lot of information, but when you put it in context, the more you know, the more you're empowering yourself to make educated decisions with your medical team. You have a limited amount of time with those doctors, and you want to make sure that your questions are built ahead of time so that you can effectively work those, doctor's appointments in those systems to your advantage. It is frustrating that here in America, at least, we have such limited time with our physicians, but you have a lot of resources online. And as I mentioned, all these support groups and these forums and all of these available resources to you, it's important to use them. The more educated you are, the better the outcome of your treatment. Now again, please reach out to PCRI if you need help with any of the information that we talked about. Subscribe to our YouTube channel because it's a great way not just to stay up to date, but to educate yourself in your particular type of prostate cancer. And please remember, most of all, you're not alone.